Recording in progress.
Hi, good evening. Can you hear me all? You guys can unmute and take part in the discussion.
Hello,
Hey, hi,
can you
Kane.
hear me?
Yes, I can hear you. Thank you so much. It is my really proud privilege to talk with you. You are one of my guru. As you know, I was at Moorfields and used to
Yes, long
see
time
patients like,
ago.
yeah, and so many patients used to see like this, and they were so happy and thankful to you. We have come,
Yeah, well, we're still there.
yeah, of course, of course.
They haven't kicked me out yet.
Yeah, you have changed so many people's life. So
Is anybody else joining the meeting?
I have sent the link to everyone on the group, so
Hi
people are
Ken.
free to
Hi
join.
Ken, it's Maria speaking.
Hi, Marie.
Yes, hi.
Hey, Maria.
So great. It's good to hear you on it. We've been having a little exchange, Chandra and I, before this meeting. You might have noticed if you've been logging in.
Yeah, we should. I will call you afterwards. Can I?
Yeah,
Yeah,
sure.
yeah, sure,
Yeah.
sure.
Yeah, okay.
Yeah, yes, give us a call after the meeting. Yes.
Yeah, great, perfect. So bye for now.
Okay. See you
Okay.
later.
See you, bye.
Okay, so what I'm going to do is I'm just going to share my screen, and I'm recording this meeting, and so I can share the link afterwards so other people can go through it, and we can have a lot of discussions afterwards. So let's see here. I hope you all can see my screen. Okay, so So at the outset, I would like to thank the group admin Anil Suri for allowing me to do this little chat with all of you, and just to steer the discussion, because I'm sure everybody have their own experiences and understanding and are successfully fitting all type of contact lenses, and I'm just trying to share what I know and what my experiences are. Recently, like last month, I have published this book on keratoconus. It's available on Amazon. If you guys are interested, you can go and check it out. This is another book of mine I published this month. It talks about the ancient wisdom meeting the science. So whatever my understanding about science and spirituality, I have merged it together for us to understand. So just to clarify my financial interests, I have no financial interest in this talk. uh, I'm going to use American technology and American terminology that may be different than what you guys are used to in UK. Just trying to share my experiences and do not want to enforce or teach you anything. And we all can discuss afterwards if there are any points that can be interesting to all. So this is a free Zoom account that I'm using, so after 45 minutes it may get shut off, and then again we can log into same link. So some of you have asked me to talk about RGP lenses also, but I'm not going to spend too much time on this because it is routinely used. People have been using this successfully, and everybody has their own understanding and share of the knowledge. Only some slides I'm going to show here just to clarify certain doubts. We have been fitting with this philosophy. When there is a tear film in between, it neutralizes the irregularities on the cornea, and one can see. If you keep too much of pulling at the center, then you may have its own problems. If it is too touching, then it will have its own problem. If it is touching especially, it rubs against the cornea, and in the long run may have issues depending on the case. Of course, we have people wearing PMMA lenses even today, and they're happy and successful. People are using high decay materials also, and they're successful. I'm not going to touch upon orthokeratology at this talk. Maybe a separate talk for the future if you guys are interested. And for keratoconus, usually these are the 3-point touch philosophies that are used, and this apical bearing is the cause of corneal aberrations in long term and corneal opacities at the center. So there are a lot of multiple curved designs came in the market, and they are been successful while fitting keratoconus. I'm talking particularly keratoconus. I think somebody's mic is on. Please mute yourself. And this touch on the cornea, feather touch you call it, and that keeps on moving up and down, and not all lenses fit properly, and some patients may have permanent corneal opacities in due course of time. So that is what makes me skeptical about this, and I like to fit keratoconus patients with scleral lenses. That is how the discussion started in our group, when I said it is punishment for the patient because it gives there is an initial adjustment time. It is a painful thing, and of course we have successful patients who are still using RGP lenses, but that is my individual personal opinion. Yes, it is cheaper, fast, and do not take much of a maintenance cost. Of course, it gives good vision.
This girl is wearing glasses. Don't believe it? Well, it's true, and here's how it's done. To make contact lenses, the eye is anaesthetised, then Sydney optician Penryn Thomas, Australia's only contact lens maker, inserts an impression cup containing a material for taking a cast of the entire eyeball. The mould sets in 2 minutes and then it's removed. A perfect impression. Contact lenses are a boon to actors, are worn by several film stars, jockeys and athletes. Yes, even glasses are made to measure today. Now the cast is put into a press and the plastic lens itself is moulded. The lens is shaped to fit its wearer's eye and also to give the same visual correction or aid that would be given by normal glasses. Now the lens is cut to shape from the plastic square and it's ready for grinding. The plastic is unbreakable and 2 lenses cost 45 guineas. In America, where the new look is popular, lenses cost 75 pounds. The inside surface of each lens is ground first, a delicate operation demanding a fine degree of precision. Instruments measure accuracy, determining if the lens fulfills its optometric prescription. Then the tiny eyeglass receives a final buffing. There's still a spectacle case to leave lying about, but of course it's smaller, just to make it harder to find. Lenses are fitted, minor adjustments are made, then a buffer solution is placed on the eyeballs and the lenses are inserted. Contact lenses can be worn for about 6 to 8 hours without discomfort. Slight haziness after this time can be remedied by removing the lenses for a few minutes. Contact lenses, invisible and comfortable. A new look that's here to stay.
So history, this was 1980, Australia, and we are again circling back to impression scleral lenses for better fitting. So as everybody knows, we keep a little vaulting over the cornea, and scleral lens should not touch on the cornea or on the limbus, and that's why it is called scleral lenses. The space in between we fill with the saline, unpreserved saline or any other unpreserved drops. Just to make it little more complete, sagittal height is measured, the distance, central distance basically. Every company will give a different sagittal height depending on from where they are measuring, whether they are measuring from the total diameter or from the landing zone or optic zone, whatever. So everybody has their own nomenclature and you can follow their guidelines. As you saw in that film, black and white, you saw a big chunk of channels there. We also used to have radial channels, like 3 radial channels, spiral channels for Stevens-Johnson syndrome, where you are expecting too much of a mucus inside, so it takes longer path to come inside, so patient can wear it for a longer time without clouding. It depends on individual case whether you want to apply the channel or not. Most of the time the scleral toricity takes care of its suction effect, and you don't have to put any channels. So most of the time the indications are keratoconus, of course, because that is where our regular GP lenses, corneal GP, cannot be successfully fitted. It keeps on moving, keeps on falling, gives a lot of bubbles and a lot of its problems. If it is a mild cone, of course you can still get away with the RGP lenses with the multi curves and special designs. Pellucid marginal corneal degeneration, here the thinning is less, so RGP lens keeps on going down, and you can overcome with the scleral lenses. Keratoglobus, penetrating keratoplasty. Because of the high cylinder, patient usually have difficulty seeing better, and a scleral lens can work. Even after intacts, many patient needs scleral lenses. Penetrating keratoplasty, as I said, PMCD, intacts, radial keratotomy became very famous some years back, and then a lot of complications because of the so much of cuts on the cornea, and cornea become irregular. Traumatic injuries, of course, can be helped with the scleral lenses. Granular dystrophies, high risk myopia, LASIK complications. Most of the LASIK surgeon has a learning curve, and the initial stages there may be smaller zone or irregularities or any other sands syndromes and all, and that can cause a lot of aberrations and halos, etc., and that can be resolved with the scleral lenses. Stevens-Johnson syndrome are the major patient load who really benefits with these scleral lenses. Instant relief from the pain and photophobia. Of course, because of the nature of Stevens-Johnson syndrome, there is a lot of mucus secretion, and patient may need to remove the lenses after 1 hour, 2 or 3 hours, depending on how much cloudiness they get after a few hours, and individual patient will be different, but this is really a boon for these Stevens-Johnson syndrome patients. So as you know, scleral lens means rest on sclera. Corneal lens means rest on cornea. So this is what terminology I was discussing with Kane Pulam just before we started this discussion. So corneal lenses, of course, they entirely rest on cornea. Corneoscleral, like a soft lens, partly on the cornea, partly on the sclera, and there are some lenses available in the market. They call themselves scleral lenses, but as you know, they are corneoscleral lenses. Mini scleral lens has a new terminology that came up after some companies tried to make the large diameter lenses smaller, and it's a in between zone. I really don't like to use mini scleral term, but it is there in the market. And large scleral, or instead of calling it large scleral, I would like to call it a true scleral lenses that rest entirely on the sclera. Now, how do I decide my diameter? This is the anatomy of the eye. So the closest muscle that is inserted in the sclera is medial rectus, about 5.5. It may change individually, but about 5.5. So say corneal diameter of 12 millimeter, you need at least 1 millimeter on both sides, that is 2 millimeter for limbal zone. So you don't want to touch on the cornea or on the limbus, so you have to land away from that. So usually about 13.75 or 14 mm, and then you need at least 2 millimeter, 1 millimeter here, 1 millimeter here on the other side for bearing that weight of the lens. So 18 millimeter becomes the ideal diameter depending on the HVID. If the HVID is 11 mm, then you can go 17 mm, or if it is more, then you can go bigger. This is a general theoretical calculation. In reality, it changes depending on the case and the cone. If the cone is high, then you need a larger bearing area to hold that weight. Otherwise, you must have seen in many cases of scleral lenses, scleral lens do not center properly. It is always sagging down and little inside. So that is because of the weight of the lens not getting distributed properly and because of the gravity. So if you can adjust that, you will get a central proper center. Different companies are there who has come up with this 1 foot lens, which is actually a mini scleral lens. Everybody has their own fitting sets. Some lenses has prolet design, some lenses has oblate design, depending on what you're tackling, whether keratoconus or just irregularity on the cornea or post LASIK cornea. So different. I have about 10 fitting sets in my practice, but most of them are like my preferred set is Boston Scleral, Zen lenses, and Visionary optics. These are the three sets I use. Of course, you need a solution to clean, maintain the surface, maintain your hygiene, alcohol strips, filling solutions, case, fluorescein, and Lisamin green for evaluation, suction cup, and plunger. We call it DMV for insertion, DMV for removal. Some fitting sets.
Chandra,
yes.
Can I ask a question?
Yeah, sure.
Can I ask you something?
Yes, sir.
What are you calling a Zen lens? Is that a mini or is it a true scleral or what? The Zen lens, you just had that on your screen.
Correct.
The diameter is
Correct.
16 or 17, isn't it? And that's in the Zen lens set. So what are you calling it? A mini scleral? Because the terminology in the UK, that's a mini scleral.
Okay. So as I said, if it is 16 mm or larger, it is okay for me to call a scleral lens. But as you said, it is a mini scleral. See, if it is less than 18 mm, you see here I have written 16 and 18 here. So this is a mini scleral, this is a full scleral. So with this I am comfortable. With this you have to be little careful with. As I said, if your cone is not very advanced, you can get away with the 16 mm also. My preferred lenses, even they say 16 mm, when I order the lenses, I order most of the time 16.5. We'll have more discussion on this again. So 14.5 to 19 mm is what is available in the market. I'm talking again about the US, but as you know, Kane is using up to 24 mm, which is is trying to cover the whole ocular surface, and that is very good for ocular surface disorders. I do use a very large diameter, that is 21 or 22 mm lenses in while I'm fitting a fenestrated scleral lens. I'll talk about it when that slide comes. Different terminology, as we know, everybody knows, sag or vault goes simultaneously. Base curve, power, optic zone, limbal clearance, limbal zone, haptic and peripheral curves, central thickness, diameter, material, aberrations, and of course optics, control and marking. These are the usually terms that we'll be using on scleral lenses. Again, every fitting set has their own diameter and limitations and advantages depending on what you like. That's why I said I have about 10 fitting sets at my clinic, and depending on the case I will choose from where to start. This is just an example of this Zen lens. They have prolet design for keratoconus and oblate design for keratoplasty or irregular corneas. So you can select depending on the case and start from there. What you don't want is the central touch, like you put a fluorescein and make sure there is no central touch, there is enough fluorescein there. You have to maintain at least 200 to 300 micron of clearance. How to measure that? Of course, 300 is usually the thickness of the scleral lens. 550 or what you have measured is the corneal thickness, and you can compare these two landmarks and decide this thickness of the tears. Try and maintain the tears all over same. For saying it is easy, but it is difficult in reality, but can be achieved. Limbal clearance also is important, and you have to make sure that there is enough clearance there, at least 150 micron. Then comes scleral alignment. This is where the fitting actually starts. You have to make sure that there is no blanching, there is no impingement, and the contour of the haptic is matched with the contour of the sclera. And that is where the challenges comes. When you go bigger and bigger in diameter, the contour is much irregular, and that is where you may get blanching and redness and other issues. If the patient is wearing it for a long time, you can even get a impingement permanently. So of course, even with the intrastromal corneal rings, patient may need a scleral lens to take care of their irregularity or aberrations. You have to make sure 360 degree blanching is not there or no impingement. I usually do this fluorescein dye test to make sure there is no seal off. That means after fitting the lens, once you have taken out the fluorescein, everything fine, when the final lens comes in, you put that lens, or even when you are doing a trial, you put the lens and paint it on the top and with the fluorescein and ask patient to blink. Everybody I think is doing same thing, and if there is a little fluorescein that is going inside, you are safe. There is no much of a suction effect. It is a capillary effect, so there is a negative pressure inside, so whatever is there outside, it is going to go inside. And again, that is what we were discussing about a day or 2 days back, about people call it a tear exchange. For me, there is no exchange, there is a mixing of tears. That molecule of that fluorescein can mix up with the water and it can enter because it is thin, very small molecules, but it doesn't come out. You can do it, you can put a fluorescein, put a lens in and wait for 2 hours, 3 hours, 5 hours, 12 hours, and see if the fluorescein comes out. If it comes out, that means there is a tear exchange, but in reality there is no tear exchange unless your fitting is not good. If your lens is moving up and down like a RGP lens, then this may happen. And make sure in scleral lenses there is no movement, no up and down movement is required, otherwise it will cause a micro trauma on the limbus. So make sure there is no touch on the cornea, no touch on the limbus, and it is nicely fitting around the sclera. Nowadays you have OCTs, and you can use OCT to see the images in all 360 degrees and make sure your lens is fitting nicely and perfect. For different ocular surface disorders, pinguicula, etc., you can have a notching, you can have a elevation, vaulting. There are variety of ways you can reduce the diameter in certain areas, or overall diameter you can reduce, and you can play around with the design and give the best fitting lens to the patient. There are a lot of instruments now, keratograph, topographers, that can be employed for fitting lenses. With the advancement of this SMAP 3D, which was the first, I thought that machine came where you can take a picture, put a fluorescein, take 3 pictures. The machine will incorporate all these 3 pictures, join them together and send it to a lab, and the lab will make a lens that is almost perfectly fitting. You just have to do the perfect overcorrection. So second lens is your final lens. Only drawback of this was it was only provided by one company, and there was no freedom to choose your lab. So then came the Eaglet eye profiler, and they have tied up with all the contactless manufacturers, where you can choose your choice of manufacturer, and you can send this data to them and they will make a lens for you. So your time is saved, you don't have to do much trial and error, and just overcorrection is required on the second lens. And if you have a trial lens of any known base curve, you can tell the lab base curve and the power, and that lens which comes is your final lens. Then of course you have Pentacam. They have amazing technology, and that can be again used to manufacture the lenses. And recently this Gaudi profiler has come in the market, and it has tried to combine most of the other features, and it is amazing. That is what I'm using right now. So it is again a CAD/CAM software that gives me freedom to do whatever changes I want, and I'm not just dependent on the consultant of the lab. So scleral lens act as a liquid bandage. So it has not only the property of giving a clear vision, but it has a mechanical protection. It can heal the surface. It can work amazingly in ocular surface disorders and gives a good oxygen to the cornea for metabolism. We'll talk about the oxygen permeability also, but let me complete this presentation first. Contraindication, of course, for blind eye, nothing can be done much, but I use a scleral lens on blind eye for a prosthetic purpose. That again I'll show you. Keratinized cornea, again it is not going to clear up. Only in Stevens-Johnson syndrome, the blood vessels which have entered on the corneal surface, that can regress, leaving a ghost blood vessel. If it is a full keratinized cornea, it's very difficult or impossible to clear it back unless there is a surgical intervention and they put a stem cell grafting and use the scleral lens as a protection. Then it can survive, and again the cornea can become normal. High risk myopia, I already talked about. LASIK complication, lot of so in 10 minutes, if it stops, again join on the same link please. We have to create ocular surface again with the oculoplastic surgeon's help and fit the scleral lens in such situations. This is what I was talking, Stevens-Johnson syndrome. After 3 years the cornea becomes normal, clear, and a patient can of course see clearly. But if they stop wearing scleral lenses, the condition can come back, because the basic problem of Stevens-Johnson syndrome is no tears, and if there is no tears, sufficient tears to keep the ocular surface lubricated, you are going to get all the issues back. Keratoglobus, of course we talked about this. So keratoconus patients are the major load that can be managed with the scleral lenses. If you see the corneal opacity because of the ill-fitting lenses or whatever the reason, then you may consider the corneal transplant. Nowadays, of course, you can do a partial thickness corneal transplants. Filamentary keratitis can be solved with scleral lenses in few hours. Graft versus host disease, amazingly within 5-6 hours the cornea becomes clear. SPKs, everything goes off within few hours, so it's really acting as a therapeutic lens. Anesthetic corneas, if you can diagnose at an early stage, because there is no sensation in the cornea and the child usually lands up with some foreign body inside and the cornea becomes opaque. So if you can diagnose the anesthetic cornea at an early age, you can give scleral lens as a protective lens. Another thing that I came across during my practice is everything is normal, but patient had a toxic tear syndrome, and we actually measured the toxicity on the litmus, and it was a really toxic. We could manage with the scleral lenses. 8-month-old aphakic patient plus 64 diopters. It was very difficult to fit RGP lenses, and it was not stable on the cornea, so we tried and fitted her with the fenestrated scleral lenses. So again, my guru in fenestrated scleral lenses is Don Ezekiel, who helped me understand and design these lenses. I made my own lenses. I in fact cut with my own hand on my own lathe machine. That helped me develop my techniques and technology. So when I say fenestrated scleral lenses, the true fenestrated scleral lens is the fenestration at the limbal zone. The moment you put a fenestration at the limbal zone, you are going to get an air bubble, and there won't be any the pressure difference. Atmospheric pressure will be same as the pressure inside, but there will be a bubble. You have to make sure the bubble keeps on moving. Because of the scleral toricity, with every blink the lens will rock a little bit and the bubble will keep on moving, and there is no localized hypoxia. And another thing here, fitting philosophy, is you have to go as large as possible, but when you look inside, lens should not get dislodged or should not move. That's where you have to stop. So you go 21, 22, 24, whatever lens you want. So you need a largest possible diameter and a 3 fenestration, because lens will rotate and at least one fenestration should be exposed to the atmosphere. That is the philosophy. This is how you fill the scleral lenses. I am sure everybody knows.
Can be filled up with the unpreserved normal saline. See to it that there is no air bubble in the saline. Fill till the top. Bend in, make your chin in, and look downwards, look into the lens, go straight in the eye, put the lens on the sclera, press the plunger, the lens is on the eye. It's absolutely comfortable. For removal, use the suction device, put it at 6 o'clock or 12 o'clock, stick it gently, twist, take it out, lens will come out. That's it.
So that's me about 15 years back. Why I wanted to show you this is, when you put the RGP lens, there will be redness, watering, because it is causing some trauma on the ocular surface. When you put a scleral lens, absolutely no tearing, no redness, and absolutely comfortable. This was the picture shared by one of our member in the group, and that is where the discussion started, the midday fogging. Now, there are two causes for midday fogging. One is, of course, the microtrauma to the sensitive sclera and conjunctiva. Second is allergic issues. If patient had a history of allergic conjunctivitis, they may show little secretion because it is going to irritate the goblet cells in the sclera, and some secretions that is created on the ocular surface will get sucked inside because there is a negative pressure inside. And even if there is a toxic tear in the transit test I talked about, there is a suction still lying. That's why that tear is entering inside and not coming out. So these debris will go inside, and cause a fogging after few hours. If it is a ill-fitting lens, it will keep on moving or cause trauma. If the quadrants are not perfectly matching, it is going to cause micro trauma, and the goblet cells will secrete some secretion, and it will keep on coming inside, and it will cause a midday fogging. Now if you look at this, the lens is again slightly sagged down. See, there is a sagging down and little inward towards the nasal side. This is most of the time this is what you get, but you can improve this fitting if you have a control of the parameters, and if your lab is ready to work with you. So of course we fill saline. There is a you can put a little jelly, like a thick salivix like solution also, to prevent this midday fogging. There is a neutrophil solution available in the US. I don't know if it is available in UK, but it has some minerals also inside, and that is supposed to be fantastic. Lot of patients have given first choice to that. It is little expensive and always out of stock. Care and maintenance also is very, very important in this lenses, because you're putting the lens and wearing it for almost whole day. So lens has to be sterile before it goes in the eye. So make sure that you are using a correct solutions, and I recommend hydrogen peroxide to be used for sterilizing these lenses at any cost. Even one infection, and then it will have a lot of other issues. So hydrogen peroxide is the gold standard. Of course you have so many other solutions nowadays, but hydrogen peroxide remains the gold standard. Make sure it doesn't go in the eye, and I have come up with this a little case where it can accommodate up to 24 diameter of lens, and the platinum disc is on the cap itself. So when you fill put the lens, fill the case and screw it up and twist that, put it inverted, so the hydrogen peroxide is in touch with the platinum disc, and it will start neutralizing. That oxygen bubbles which are coming out will sterilize the lens. This is how, just to show you, see, it reacts immediately. And you can use a normal hydrogen peroxide which is available in the chemist. 3% hydrogen peroxide is available. Only problem with that is it has a inhibitor mix, so that the hydrogen peroxide should last longer. So that will remain, but lens will be sterile. So once the lens is sterile, you can clean up with your normal saline and other solutions, and it is a sterile lens, you can use it. This is just to save if you like to advise or use it. Of course follow-up is important, next day, 1 week, month, 6 months, and every year. If possible, in India I do clean up protein removal on the lenses also. In the US it is difficult, but of course there is a Progent, that is a solution available that can dissolve the protein on the surface. Of course during the follow-up you do refraction, vision. We also do topography, because patient is going to ask me whether my keratoconus has increased or not, or stable. So that helps me understand and explain. Nowadays the technology has come in the US called HydraPeg, where you can have a polyethylene glycol coating on the surface of the lens. It is about 3 to 5 micron of very thin Elizabeth, I'll give some time for other people to join. I think most of us have joined, so I will continue my talk.
Are you going to continue recording as well?
Yes, I'm continuing recording also.
Recording in progress.
Okay, I think we can start here again. So I was talking about the surface coating, and it is really helpful and amazing for dry eye patient especially. You can actually, if your lab is offering this, you must use this technology, and a patient will really thankful. Only issue is sometimes if they use alcohol or any other little abrasive solutions, the coating can wear off because it's 3 to 5 microns, and it is sometimes very uncomfortable if the coating is gone. You can ask your lab to recoat it. Some labs will offer that. The main company who came up with this is Tangible Hydrapeg. They came up with the boost solution, that is every month or so you can actually soak your lenses into that boost solution and it will maintain the hydrophilic surface, but most of the time it is not available in the market or out of stock, but it is really good way to help dry eye patients. See, we have been fitting these lenses. I think Kane has been fitting lenses for decades, and he never used maybe, and still he is comfortable. Even we started using recently. So new technologies are always there, and it depends on how you adapt. And if you like it, you must add it to your practice and make use of it for your patients. Coming back to the fitting aspect, so sclera is usually not always fully spherical. There may be little here and there, and not very toric also, or sometimes very toric, or if there are any peduncula or bleb surgeries or any other surgeries has happened after cataract surgeries, the shape may change and you may have to modify your haptic accordingly. So as I said, this is my most of the time I use Boston fitting set because I was the first fellow of Boston Foundation for Sight at that time with Ferry Rosenthal, and it's kind of my baby, so I know most of the parameters and most of the developmental things that happened, and it is giving me a lot of freedom to modify my lenses. This is how I design. This is how you get a link to the online software. You can feed in your diagnosis, patient details, right eye, left eye, and what lens you use from the fitting set. Select that, and then you put a overall over refraction that you used. You can select your material, what you want. You can put instructions. You want a dot, one dot, two dot, clear dot, what diameter you want to modify to. Even if you use 16.5 mm lens, you can write I want 17.5 mm, they will do it. Limbal clearance you can change, haptic modification, toricity in quadrant space. This is a in 4 quadrant, it will allow you to change the toricity, that is you can go steeper or flatter. It can allow you to change the base curve as well. So you can have a prolate or oblate design according to your cornea, and you can submit it. There is one more feature where you can have the channels also in the degrees.
Sir, we
you can
cannot see
mention.
your slides, sir.
Oh really?
Yeah.
I'm sharing. It is okay. I'll stop share and again do it. So from the beginning you never saw?
Just few slides ago.
Can you see now?
Yeah,
You can see?
yeah.
Okay, so let me go back. I think coating is okay. This is where I think I need to explain. So the quadrant specificity, and this is what the fitting set I use. Different this is the central is the mostly used, and then you have a flat haptic and steeper haptic. You have front surface eccentricity. You can go two different front surface eccentricities for taking care of high order aberrations, and this is what the software you can log into once you have the account with Boston Foundation lenses. Put the diagnosis, then you can select right eye, left eye, what lens you use from the fitting set. You can have a fresh surface eccentricity changed if you want. You can select the over refraction that you did, the material choice you have, and you can comment. You can increase the diameter, decrease the diameter. You can change, ask them to increase the thickness. You can change the limbal clearance. You can change the haptic toricity in different, that is 4 meridians you can change. You can also change the base curve. I think participants need to mute their phone or laptop. So base curve also you can change depending on the cone you have to adjust that tear thickness, and you can submit. There is a feature for creating a notch or the channels, radial channels in the lens also on the software. Then came the iPrint Pro. Christine Sheen, my friend optometrist from US, tied up with Keith Parker of contact lens manufacturer company, and they came up with AVT or iPrint Pro, and taking the impression, scanning it, and making a lens out of it for really difficult, sclera like a bleb or something, and it's amazing technology. So this is how you take the impression of the eye.
So this is the silicon, facial silicon that won't cause any irritation. Okay. You wanted to look downwards.
I think somebody is talking and we can hear it. So if they can mute yourself.
Straight.
Let me see if I can mute. Okay, I managed to mute. Okay.
Look down. Thank you.
Oh,
This is the shape of your eye. See? Beautiful.
let me share it again.
Thank you. I'm going to take the impression of your eye, okay? So this is the silicon, facial silicon that won't cause any irritation.
Okay, I'll just go on to the next slide.
Okay?
You can see my slide, right? So it's the same repetition of the first impression, but here I'm going to show you. See, there is no anesthesia, no nothing. Ken has been doing this for years, so there is nothing new in this, but this is what the next step that is new. So once you get this impression, you can scan it and convert it into a digital file that you can edit on the CAD/CAM software. So you put a little spray and make it opaque. A thin layer of this white spray, so the shiny part is gone, so it can be scanned. So after once this 3D scanning is done, you get a base of the lens. Front surface you can design depending on the power and the thickness in the software, and this can be given to the lathe machine to cut. So nowadays lenses, the lathe can cut a free-form lens and any shape can be cut on these lenses after taking the impression. And funny lenses can be made, but absolutely comfortable for the patient to cover the, and you see they are quite big, large lenses, as me and Ken was discussing about few minutes, about 20 to 24 diameter lenses. Now another technologies are available, because most of patients don't like that glue to be going inside and they are already sensitive. So you can use the topographers. Of course, MedMount is good for RGP or orthokeratology because it covers only up to 10 mm to 11 mm of cornea, and it really doesn't give much information about the sclera. So here the mini sclerals or 15.5 16 mm lenses can be managed with this, but the true softwares are this eye surface profiler, so Eaglet, which is very famous and doing wonderfully well in the US and other part of the world, and of course the Eaglet. Pentacam XL wave has one step more, where you can have a aberrations also measured, and that can be incorporated on the optics and patient can really see crisp and clear. So they use Chamflug technology to measure front and back and the total eye also, and they can measure the aberrations. The periphery also is measured, and that can be used for Gaudi software, Gaudi scanner or a software. Eaglet of course does its own thing and gives a perfect fitting lenses as far as the haptic and even the thickness etc. you can design in this software, and the lab can make a wonderfully well fitting lenses. This is how you get the maps, and it has a lot of other features that can be incorporated. Even for Pingengula and all, you can have a bumps and walls also. So they have tied up with all these companies. As I said, I have only the information about American companies. I don't know much about UK manufacturers, but I'm sure you can relate with your manufacturers and you can talk with them. So Gaudi is my preferred software nowadays. So it has a lot of features. It can do fluorescent imaging or without fluorescent. You don't have to put a fluorescent. It will give IR mammography. It will give the impingement, blood vessels. Everything can be seen with this, and any irregularity can be adjusted with this machine. This is, I'm going to show you a little video here. Again, I have no financial interest in any of this, just sharing my information and knowledge. So this is how the face looks like, and it is a free-form lens. You can actually modify as you want in any meridian, not only quadrant, like not only 3 4, but here you can have up to even 10 degrees modification possible. So if you are using Gaudi profiler, then you can actually take the image and it will automatically go on the software, and it will design. So this is the eye, and then you can add the lens on the top. So this is the lens that you are adding. This is how it looks. I'll just show you my software on the laptop. Hopefully I'll be able to show you. So you can actually see 360-degree and modify accordingly. Okay, let's see. I'll just show you my software. Okay, again I have to show let's see here. Okay, you can see my screen that is converting my file still. Okay, so this is what I wanted to show. Okay, so
We can't currently see that, Chandra.
you can see this. Okay, I'll just again do that. Can you see now?
Yeah.
Yeah. So see, this is the eye. As you go away, this is irregularity. See, they're not, the eye is not exactly spherical. You can see, and this is your choice of the lens, and I am saying say 250 micron clearance I want, thickness is 300, diameter is 16.4, base curve is 8.23. so I will add this lens, suppose apply. So it will show in a different color. It is constructing the lens. And this is how the lens back surface looks like. This is the front surface, right? So now if you go a little down here, let me see if I can go here. So this is the meridian view. Now see, if you see, it is going inside. So obviously you don't want this to happen. So you can have a diameter cutoff here. You can change this limbal clearance, everything you can modify. See, this is how the lens is showing in a different meridians. You can change the degrees and you can see where it is touching and what is happening there, and you can modify accordingly. So full control, you have full control of the lens designing. Okay, let me go back to the presentation. Do you see my slide still?
No, not yet.
No? Okay, I'll again stop sharing and again do that. So you will see my slide. Can you see my slide now?
Yeah.
Wonderful. Okay, so again a short video.
Dr. Valens. These defects are called hyper-order aberrations, which can cause serious vision determination in these runners, halo, and double vision if not properly treated. When measuring these aberrations, it is not enough to simply scan in with your sensitive forceps. What's needed is measurement of these hyper aberrations.
Okay, so that was about the high order aberration. As we have seen the progress of the technology over so many years, yes, now we are fitting a scleral lens perfectly well and all, but still patient is seeing 6/6 or 20/20, what you call it. But always some patients will say, no, I can see double, I can see two A's or two E's or two, double images, or there is a, a glare in the night, still they have difficulty driving, and that is where the aberration comes in. The surface on the cornea, that irregularity, those aberrations can be controlled with the contact lenses, the scleral lens or RGP lens, because that water will go into that irregularities and fill it up. But back surface of the cornea, if it is irregular, front surface of the crystalline lens or back surface of the crystalline lens or the media or the the retina, the axial length, if these are the culprits, then you are stuck, and hey, this is what maximum we can do. Patient used to be happy because from blindness you brought it to 6/6, 6/9. But some people are still not happy with that, and nowadays, because of the advancement in the technology, we have understood the aberrations, just the basics of low order aberrations that we every day correct is basically a tilt that can be corrected with the prism. Second order is defocus, that is myopia, hypermetropia or astigmatism. So this can be corrected with spherical, cylindrical, plus minus lenses, and of course with the prism. But when it comes to third order, fourth order aberrations, that is coma and trefoil, this was very difficult to treat. If it is a surface, then of course you can get away with the scleral lens, but if it is back surface or in the media inside, then it is difficult. Fourth order aberrations again introduced because of the multifocal lenses or IOLs and all, that we are actually choosing to put in for bifocal or multifocality for presbyopia. But if there are any refractive errors that has happened, changes because of the surgery, then again that can be tackled with the high order aberration optics on the scleral lens. Of course, the aberrations are dependent on the pupil diameter and it can change, and some of these aberrations cannot be corrected with the glasses. Again, to understand aberrations, it's called point spread function. So if there is a point source or point light or point object, the retina or the eye should have a point image on that, right? If it is not, if it is defocus, then it can be corrected with, as I said, spherical lenses, minus or plus. If it is horizontal or vertical line kind of thing, astigmatism can be corrected. But if it is like a coma, spread it in different direction, trefoil, then a regular spectacle lens will not correct it, and you need a special optics. So consider a wave. Okay, now before going into that, the wavefront is measured. They put some different rays of light inside, and those rays comes out. If they come out from the same hole, it is normal. If it gets deflected, you are measuring the aberrations. So this is what, this is more aberration, this is less aberration. So So that point spread function is measured like this and quantified, and that is turned into a wave, or to understand where it is up or where it is down. So just to make it more simple, this is the cornea front and back, this is the lens front and back, and the axial length. So that machine which is measuring the total aberrations, not only surface. The topographer will measure only surface of the cornea. Pentacam will measure front and back, and of course the lens also, but mostly it is talking about the front and back. The Ovids and the AXL wave software which has come up in Pentacam now is measuring the total aberration, and now that total aberration can be measured and controlled or corrected. So just to give again a image, this is like a Pringle wafer. You can see it is going up and down like a wave, right? This is like a double wave. Of course it is pupil dependent, but now you can measure. Once you measure, once you know the problem is half solved, right? Then you can find a solution. So understand how the sound wave gets cancelled. There are headphones that we use on the plane to cancel noise. So if there is a crust, you put a trough and you nullify or cancel. So same thing can be done here as we used to do for hypermetropia and myopia. The same way, same principle is used and corrected on the front surface of the lens. So for that, first of all, you have to measure. So this is there are some dots, so that to understand whether lens is central properly, not rotating, and which direction it is. So the base lens is put on the lens. First of all, you have to get a perfect fitting lens. Once that fitting lens, central non-rotational lens you achieve, then the lab will send you this type of lens. So you put this, and then again you measure the aberrations. Now this aberrations that you measure, the lab will create a negative aberrations and put it on the front surface of the lens, and then you put this lens and it will neutralize. This is how it is represented. So Ovid's X-Wave technology came up in the market, and right now I have that, as well as I have Pentacam AXL wave. So again 10 minutes, if it gets disconnected, you guys can again log in using the same link. So this is what I've been using. This is the chart that I see. So RMS factor, that is what we are looking at. If it is red, see this vertical comma, point spread functions. So this helps me to educate my patient. This is what is happening, and we measure this, and this is how we do this. So just inserting the patient's data, name, date. I conduct these small training sessions so that I can spread my workload to others, let other people also do that. So these are the Zernike details. This is the representation in color. This we already discussed, and once you understand this, you can neutralize that and apply it to the patient. So the lenses, usually, again, right now it is a trial and error kind of thing going on, so you may need a little extra lenses, like 2 or 3 lenses to get a perfect lens, because once you get that fitting final HOL lens, again you can do the measurement, and if there are any aberrations still left, that you will communicate with the lab, and the lab will send you another lens. So third lens will be your mostly last lens. So this is another, just a case to show patient was improving up to 618 with scleral lenses, 612, nothing beyond that. So that is where the aberration came into picture, and he had too much of vertical trefoil coma, horizontal coma, and after fitting the eye order aberration scleral lenses, he improved to 6.6. and patient was quite happy. This is his other eye. In the left eye, where there was not much of an aberration, he improved to 6.5. So last few slides, just I use this advanced technology of fitting scleral lenses. As of now, I again, thanks to Moorfield Hospital, where I did my Ocularist retraining, and that's where I learned how to make artificial eyes. And then I went on perfecting further, and I developed a technique where I can paint on a RGP scleral lenses to give the prosthetic effect. Of course, I can paint on soft lenses also, that I learned from Cantor and Nussel when I was in London. And you know, you really get a good prosthetic effects. Not 100% because the color will show different in different lighting conditions, but you can fairly give a better results and make a positive change in the patient's life. You know, corneal opacities, fixed dilated pupil, aniridia.
So like I was saying,
You know, this is a patient of
3 years
glaucoma,
ago,
corneal
they actually
opacity,
laid us off.
and you
It
can
was
see
about 170
amazing
of us,
results with the
and they chose
iris
30
painted
of us,
scleral lenses.
which I was one of the
If it
30.
is
So,
tinting,
Chandra,
yes,
you know, I
can
felt
I ask a
ecstatic at the
question?
yes.
time that they
Is the
offered us
painting
room
encapsulated
to.
within within the polymer, or is
No,
it just on the surface?
it is well, it is not on the surface. It is penetrated into the matrix. That is where I do the tinting. Okay, I will not explain you details how I do it, but it is penetrated into the lens, so it is permanent, and it will lose about 30% of the oxygen permeability if I am using a tinting. So most of the brown shades tinting works perfectly, and patient can have a much better color effect or matching effect. Of course, this what I am showing right now is a soft contact lens where I have painted off center iris, and this is a soft lens because she has a very divergent squint. So coming back to your question, Ken, if it is a opaque layer that they want, then what I do is I put a opaque layer at the back. So I do the tinting to match the color, and most of the time there is a open pupil 3.5, 4.5 or 5 mm pupil through which patient can see, and I create a opaque layer at the back of the lens. So that is where I need about 90 microns of extra clearance when you are fitting a lens at the limbus as well as at the cornea, so that I can incorporate that opaque layer back, and patient can see normally clearly after the surgery or whatever the issue. See, like this, you know, the patient has so much of lost iris, and I created an artificial iris here. So here, wherever there is a painting, all 100% oxygen is blocked. You cannot allow, the oxygen won't pass. But this central 3.5 or 4 millimeter area, which is clear, and this 12 millimeter to 13.5 mm of landing zone, that area allows the oxygen to pass through, and patient can get about 30% of the oxygen, you know, whatever decay by T. So use a high decay material here and get away with that. And see, if you, there are a lot of arguments happening about the oxygen. See, we are using a soft lens and giving comfort. The soft lenses gives only 15 decay, whereas with, you know, if you use 120, 140 or 160 decay material, you easily have more than 20-30 decay available to the cornea. This patient had a normal surgery, retinal surgery, and she started having a diplopia. So she wanted me to block the eye, light coming to that, and we created a fully opaque lens here. One of the patient actually asked me to give a black eye oil, which is not available anywhere in the world. So I specially made a black eye oil for him, and you know, he did just don't want to see with that eye, but he didn't wanted to enucleate or eviscerate, because otherwise the eye was normal. Of course, I do this prosthetics thanks to again Moorfield's Eye Hospital, and we can really change the life of patient. This is what I use technique for my film industry, movies. These are special colors, special treatment is required to fix this color, non-toxic, and special material is used for that. again thanks to Fanter and Nissel for teaching me this. I've been using these special effect lenses for the films. Bollywood is mostly Hollywood, televisions, drama. You may not know this, but some of you who are familiar with the Bollywood cinema may recognize some of these superstars. I was fortunate to work with all these people on the set. I usually don't go on the set. I send my optometrist, but sometimes they insist and you have to be there. This is the recent TV serial which became famous in India. This is the assassination of Rahul Gandhi, and we have given a prosthetic soft lens to make the actor look blind, and then again he is wearing a artificial eye on the top. Okay, so some other actors, actresses, these are the recent movies. This is upcoming movie Gandhari. I was featured in the very famous magazine in the US for my gold and diamond lenses. This I got patented, and real diamond jewelry, real gold can be used on the eyes. This is how I became famous all over world. This is in fact a model from London, Suki. So there was a La Figaro magazine from Paris. They came to Mumbai for shooting, and we have to get a good models to shoot for them. Some of you may have seen this video that went viral. Yeah, it's in soft gold contact lenses. I'll just squeeze this, and this is how I look with the lenses, gold and diamond. I'm working on changing that gold and diamond, that is about 300 micron of area, with camera, display, power, Bluetooth, internet, medical, can be used as a medical device, surveillance, recording, working on it.